So I'd now like to welcome Renee Mendes, who's our Residential Aged Care Manager for Western New South Wales Local Health District. Renee's been nursing for 30 years in a variety of health settings. She's driven to change the paradigm of aged care within our multi-purpose services, and she's absolutely fabulous to work with an amazing dedication to all of our residents in our MPS, and we're very lucky to have her. Today, she's talking about what does dignity of risk mean in the context of a health environment and understanding the concept from a resident's perspective when we care for people in such a safety-driven world. Welcome, Renee.
Thank you. Thank you, everyone. Okay, let's start here with this photo. So what are your first thoughts when you see this photo? Quite uncomfortable, isn't it? Especially when you take into account, you start to really break that down. You have an elderly lady standing on a sleeper in socks, parked a walker, and she stepped up to peer over the fence. This is my grandmother. She's 95. On a visit, I went to visit her one day and she asked me if I would take her out for a walk in the garden. She loved her garden. So we did. We went for a walk. I knew she had a hidden agenda. She has been dying to have a look what's going on over that fence. So I was facilitating her doing this. So I didn't think this was going to be a problem. I thought she's not going to be able to stand up on that step. We'll be fine. This will be okay. But she did. She went, and she very, very easily, 95. She just stood up and bless her. And so I thought, oh well, I'll stand up there with you. We'll just have a bit of a chat. And she leaned over to me and she said, "Thank you, darling." Because I knew that. Sorry. She said, sorry. Right? Sorry. She said, "Thank you, darling, for letting me do this." She said, "Whatever you do not tell your mother, and you do not show her this photo." So I'm showing you instead. I'm still not showing my mother this photo. Lovely. So I guess this is a really good example of what we can do, and certainly not within our healthcare environment, but in a home environment, is allowing somebody to take dignity in making a choice, to take a risk, and we support that. Because I can guarantee you, with my grandmother being as spicy as she was, that she would have gone and done this without me. Yeah. So of course, I'm the whole time going, "You're going to fall, you're going to fall, you're going to fall, you're going to fall." So it's really just trying to suppress that a little bit and support the risk taking as best you can. So I just wanted to illustrate. I'll give you an example of that. Okay, so moving into residential aged care. So historically, what has happened when this occurs is that the person will move into residential aged care, and our natural instinct as healthcare providers is to wrap people in cotton wool. Yeah, so we care for them in such a way that unfortunately this contributes to deconditioning and frailty. And I'm talking from a historical perspective as well. And this is because we're bringing people into our care, we're cooking for them, we're cleaning for them, we're assisting them with every aspect of their lives. We can do it for you. And in doing that, we're taking away their skills. We're de-skilling people. So it's really important that we keep this in mind. So we work in a safety culture within residential aged care, and we're in a model of an acute model, and we're trying to amalgamate a residential home-like environment into an acute model. So it's quite challenging, and I spend my life working in grey, varying degrees of grey, but certainly in a grey area. So Professor Joseph Ibrahim, the head of Health Law and Ageing Research Unit at Monash University, where he's articulated the concept of affording a person the right or dignity to take reasonable risks, and impeding this right can suffocate personal growth, self-esteem, and overall quality of life. So dignity of risk, what is it? So other older people that have been managing their lives and making their own decisions for many years. Decisions should not be taken away because they have moved into care or because they become more frail. Dignity of risk is another way of saying that a person has the right to live the life they choose, even with risk. And that dignity of risk sits within Standard 1 of the Aged Care Quality Standards, Action 1 of the National Standards Aged Care Module, and is outlined in the Charter of Aged Care Rights and the Aged Care Code of Conduct, which we are all governed by. So duty of care. I'm sure that's a term that's all popped into everyone's head while we're talking about dignity of risk. What about our duty of care? So our organisation and staff have a responsibility to the residents to reduce or limit the amount of harm or injury that may be experienced. This responsibility is known as duty of care. The responsibility to do no harm and to take actions where necessary must be balanced in a way that is respectful to the residents' rights and wishes. To breach duty of care, harm has to have been caused, and that we have knowingly put the resident in the situation of substantial risk of harm. We often use the wording duty of care out of context, and we are providing care for residents knowing that the care is suboptimal. This could lead to a breach of duty of care if a reasonable person under the same circumstance would have taken precautions against the risk. So the tension between duty of care and dignity of risk should not prohibit the ability for an older person to be involved in decision-making process and express the choices that enable them to live a life that they choose. So dignity of risk is in itself a duty of care. So managing the balance. How do we support the balance between dignity of risk and duty of care? So the ability for the residents to make their own decisions, using person-centred care models, robust care planning, the robust management plans, and meaningful engagement all allow us to support dignity of risk. In knowing that dignity of risk was a relatively interesting concept in an acute-based model, we decided the best course of action was to provide some governance at a local level to help support and for the staff to feel comfortable and safe in allowing residents to take risks which would, in some instances, not be supported. So we have a residential aged care supported decision-making framework in the form of a guideline. This is a process that allows the staff to run through a step-by-step instruction on how on how you can support the residents in taking that risk. So an example of that may be where a resident has decided that they no longer want to have a cup of tea that's thickened. So how do we support the resident in order to take that risk of not thickening their fluids with potentially poor outcome, and enabling us to feel comfortable as an organisation, and then also allowing the residents to undertake that level of risk. So in doing so, we have the allied health professional involved in that decision. We make informed choices. We inform the resident or the resident's substitute decision maker, depending on capacity. Of course, capacity comes into this as well. So we are making sure that from an organisational perspective, we are doing what we need to be doing, but we're also balancing this with the resident. So I would love everyone to have a look at this guideline. I've had a lot of input into this guideline, and we also have management plans that align with this as well. So from an allied health perspective, certainly it's a fantastic document in order to allow us to support our residents. So I've also provided some resources and a YouTube clip that, and this YouTube clip will explain dignity of risk, the balance of dignity of risk and duty of care much better than I can ever do. So thank you. I'm probably running too quick, but thank you very much.
Thanks, Renee. Lots of food for thought. Has anyone got any questions or discussions for any of the presenters this morning before we do break for morning tea? Renee, could you maybe just give us an update on the consent forms for dignity of risk? You didn't talk about that, did you, while I had to go? No. Just because there's a bit of a change in the wind with that, and it'd just be good to know what's happening in that space. We've developed new in an evolution of quality improvement of guidelines. The documentation was quite extensive in order to allow people to feel more comfortable about the process. So what we've done is we've evolved this a little bit more now, so that the consent forms that we'll be using for dignity of risk, we've also aligned them to be a little bit more generic across residential aged care. So there isn't an actual consent form in New South Wales Health for residential aged care in restrictive practices environment as well. So we've developed a new form around consent. And so that's currently, actually I've just received the order number for that, and so I'll be able to send that out for everybody. So just allowing to make sure that, we're covering ourselves, but we're also supporting the resident. So does anyone have any questions?
Slightly different, right?
Sure.
There's been some discussions around the behaviour management focus last year.
Mm-hmm.
To let people know where that's at now.
Mm-hmm.
That's really key as well.
Absolutely. Absolutely. Yeah, yes. So with the behaviours. Sorry?
Could you just repeat the question?
Yeah, so Lorraine asked me around behaviour support planning and the importance of that in residential aged care. Yes, so with the behaviour support planning, we, with the ever-changing world of aged care with the reforms, we have, what we're doing in Western is we use an acute tool. So what we are working with is trying to work within an acute tool and align a residential model to that. So what we have done is I'm working with the EMR team currently in order to develop a better behaviour support plan that will sit in EMR. And this will allow for all of the staff across all of the districts, not necessarily just within residential aged care, but if you're working in an acute setting or in a community setting, you'll be able to access this particular document. And the idea of behaviour support planning is that we are trying to help and support people with cognitive impairments who may have behaviours and psychological symptoms of dementia in such a way that we reduce the use of restrictive practices in order to control those behaviours. So that is the aim. It's modelled a lot off the NDIS in positive behaviour support planning, which I love it framed that way because that's the way we should be framing this, but it's more of looking at unmet need. So it's assessing the resident and knowing the resident in a person-centred model, so really understanding the people that you're looking after and developing a plan that is specific for them to help understand what their triggers may be. And it's also important, so important to involve the people that know them the best in this process. So I'm really working hard on trying to develop some really good management plans within residential aged care, rather than just risk scoring everybody. Risk scores are fantastic in their context, but really don't give us, really ground roots strategies in order to help manage, any aspect of a person's life.